Hi guys, we are doing our pico presentation via Chili's. So this is our attempt at it. It's a little, the lighting and the sound is a little different, but we're gonna just start it. Okay, so it's me and Tony and Janet, and our pico presentation. If I get out of the light, it's because then you can see our PowerPoint. So our pico presentation is on CAUTIs, catheter associated urinary tract infection. So our population is catheter patients. The intervention is straight catheterization. The comparison is between two regular indwelling urinary catheters, and the outcome that we desire is to decrease UTIs for the inpatient. So basically our question is, in catheterized patients, how does a straight catheter program compare with indwelling urinary catheters in decreasing UTIs? Well, it's simple. Monitor your patients and see if it's necessary then to remove it. All right, as you can see, naughty, if we cause a CAUTI. Indwelling catheters are not indicated for incontinence with no skin breakdown, if they are unable to ambulate, morbid obesity, patient request, confusion or dementia, or patients transferred to the ICU to the unit. So Foley's are indicated for acute urinary retention or obstruction, assist in healing of perineal or sacral wounds for incontinent patients, hospice, comfort, palliative care. Required, Foley's are required immobilization for trauma or surgery. And you must do I's and O's in the critical ill patient, I's and O's every 1 hour, or if they are mechanically ventilated.
You remember ever watched Demolition Man?
So, as you can see, urinary catheters confine patients to bed, making them more immobile and thus increasing the risk for skin breakdown. No one wants a sore bum. All right. Hi.
So it's me now. Let me see. So I want you to see the slide. Okay. So here is the comparison and the real truth. CAUTI's UTI is the most common complication of all caths. The daily increase in UTI risk when using an indwelling is approximately 5%, and there is a 3 to 10% daily bacteriuria incidence. Gross. So we want to pull that catheter out. Intermittent catheters are reported to reduce the risk of infections as compared in indwelling catheters, and as an example of 20% reduction is reported after just a short-term post-op use. Recent research suggests that infection rates correlate with the occurrence of multi-drug resistant bacteria, yikes, and are more common in indwelling cats. So intermittent straight cath is the gold standard. Studies have shown that IC has been found to reduce the risk of upper urinary tract deterioration, enable faster return to normal voiding, shorten hospital stay after surgery, and improve the possibility of renal recovery. In addition, IC, when practiced on demand only, appears to be the best practice for bladder management. It has, however, been shown that IC can be successfully taught to a very high portion of patients, 84%, and as high as reported preference among users, 97 to 99%. What do we want to do? We want to remove that catheter. Foley catheters can cause an increase in A, infections, B, length of stay in a hospital, which will increase the cost for hospitals and for the patient, and it's very uncomfortable for the patient, and it will just use you won't use as many antibiotics.
JJ.
Hi, Jan's here. So, Medicare reimbursement guidelines. According to our favorite Brooke Giddens, Medicare will not cover the cost of a preventable hospital-acquired conditions, mistakes, and infections. Medicarare's new ruling states no CAUDIs. That means we as nurses won't be able to participate in the pay for performance incentive program that we actually had to do a DB on. That's a bummer. If we don't do our job and focus on patient care, the infection rates, we will miss out on the hospital reward program and receive a gift card for a free meal in the cafeteria. Bummer. I always loved Taco Tuesdays. For instance, we would have shown you the sheet, but on every pod in the Elmhurst floor, they were showing an increase of incidents, and they were going to get a free gift card to the cafeteria for their scrumptious meals. Oh, wait. I have to go back.
Okay. Sim.
Okay, so for instance, our SIM 2, scenario 19, patient's initials were DM. Our last simulation, our patient DM had a spinal injury which caused paralysis from the waist down. A Foley was not used. A straight catheter program was going on to be the outcome for relating to the injury. However, during bedside handoff, the night nurse did not check the patient's bladder or straight cath the patient, resulting the patient had an autonomic dysreflexy response. The bladder scan read 500 cc's in the bladder. We as nurses must provide quality care by not only implementing straight catheterization, but actually implementing the 2 to 4 hour bladder care program. So conclusion. Remember, we as nurses want to take care of people and not cause pain or infection because we were busy or too busy. Bladder care programs take additional time, but only every 2 to 4 hours. We as nurses can straight cath a patient and reduce their risk of CAUDIs. When your patient has an indwelling catheter, check the length of time and the patient has had it. Look for signs and symptoms of infection, such as a fever or different looking secretions around the insertion of the catheter. Pico is our mate. I feel after this assignment, we will be better educated and be proactive in providing the best standard of care for our catheterized patients. Thank you very much on behalf of Jan. Oh, and now I'm going to hand it over to Karen, and she will be giving you a little more information.
Okay. Real quick, guys, had we been in person, we would have handed out these worksheets to you guys, okay? Because another option for reducing CAUDIs is doing the external female catheter called the PureWick. And at Elmhurst, our awesome clinical, they use it there. And we were able to assist even in applying them. So it is, if you can see this, it's basically...
Get close up on that.
Well, how about this one? No, but as you can see, this is the real PureWick. And I was able to help assist in applying it. As I said, sorry, this is hard to... Oh my gosh. Okay. So you basically clean the area, spread the labia, and you insert this, and you not even insert it. It is not internal, so it doesn't have to be sterile. You just apply it nice and snug, and then you turn on this wall suction, and as the patient urinates, it suctions it away. So as you can see, this shows where it is attached to the wall suction, and basically then you just throw it out when you're done with it. And that is also proven to reduce CAUDIs. So that's it.
Thank you very much.
We are.
Yeah,
you
we're
guys
gonna say
all
bye.
Say hi. Bye.
Hi.
Bye.
Hi.